um, and that is Dr. Blosser. So Chris, go ahead and proceed.
Good morning. Steve, that was a fun talk, and I really appreciate how, despite my topic being much more of a Western oriented discussion, I think there's the same interest in meeting the patient where they are at. And so can you see my screen?
Yep, looks good.
Great, okay. So what I want to talk about this morning with you all is the concept and the topics around cancer in patients who have kidney disease. A couple of disclosures: I have some funding from the Cooney Foundation, consultant for Natera, and I'm part of the AJT board. I want to talk with you about the incidence, mortality, and risks for common cancers in people who have kidney disease. We will discuss cancer screening recommendations as they currently stand, and also discuss waiting times for people with cancer that are looking to get a kidney transplant. I don't plan on talking about treatment or management of specific cancers. Dr. Malik has a great onconephrology clinic here, and I think he continues to serve those patients well. I also don't plan on talking about management of after kidney transplant cancer. That's a talk that I've given before, and I, at this point, want to just acknowledge that this is an increasing part of my work, the intersection between cancer and transplant, but both before and after transplant are components of that consideration. So I want to start with a case, and this is a 68-year-old man who has a history of type 2 diabetes and hypertension. At the time that we met him, he had stage 4 CKD and was referred for transplant evaluation. During our workup for transplant, we found that he had a stage 3 clear cell kidney cancer. It was something he did not notice, didn't have any symptoms at the time. And so it was a surprise to him, of course. And of course, then the questions were many. And it led to him undergoing a right laparoscopic nephrectomy and starting a tyrosine kinase inhibitor. Unfortunately, that resulted, or he thought it resulted in dyspnea, but in reality, over the course of the months after his nephrectomy, he actually experienced progression of his cancer and was found to have pulmonary metastatic disease. So there were many questions that he came to us with, and we were discussing with his nephrologist and oncologist, such as what systemic treatments to use. Should this include immunotherapy? Will the treatments that he gets impair or impact his health and kidney function? Will the treatment actually improve his survival or not? What kind of surveillance would be indicated in these cases? Would he be a transplant candidate if he achieved remission, and after how long? And finally, that was all with the importance of considering what he wanted in this care. We know that cancer remains the second cause of death in the general population. Unfortunately, there's even a greater incidence of cancers in patients with chronic kidney disease, end-stage kidney disease, and kidney transplant patients. That risk does increase over those 3 types of experiences with kidney disease, from about 1.5-fold higher than the general population in the CKD, especially latter CKD population, and increasing to kidney transplant patients who have a 2 to 4 times higher risk of cancer. The Australian registry, the ANDS data registry, is probably the most robust when it comes to analyzing cancer incidence in these different populations of chronic kidney disease, end-stage kidney disease, and transplant. And you'll notice that probably the most comprehensive assessment was this registry analysis that was published in 2006 in JAMA. They looked at over 28,000 patients who were 5 years before dialysis, but with CKD diagnosis, along with those on dialysis and after transplant. And you'll notice that the standardized incidence ratio, meaning the ratio of cancer in the population compared with an age and gender matched general population, was higher for all of those and increasing over those. So it was 16% higher and significant in those with chronic kidney disease, 35% higher with dialysis, and 3.27-fold or 327% higher in the transplant population. This is an Australian and New Zealand population, so it is slightly different than ours. And I'll also note that they excluded non-melanoma skin cancer along with urologic and myeloma cancers because of how those cause end-stage kidney disease. I also want to highlight that many of the cancers in these populations, in our CKD and end-stage populations, are related to a number of oncogenic viruses or the urologic system. So the most common cancers that we see in the US in CKD and ESRD are multiple myeloma, along with urologic cancers such as kidney, bladder, and prostate. Liver is significantly higher, and along with skin, cervical, and Kaposi sarcoma. And those bottom four include associated risks with specific viruses, liver with hepatitis B or C, along with HPV and other increasingly known associations with viruses. So we know that there are specific associations between cancers and the resultant end-stage kidney disease population, and you see those on a regular basis, and those include the myeloma, the kidney cancer, and the lymphoma. Also, medications for treatment of cancers result in progression of underlying kidney disease, and unfortunately that remains a challenge for our patients in ways that limit their abilities to have mainline treatment. The risks for cancer remain in our patient population underappreciated, I believe, and that of course includes age, but I think increasingly we understand that chronic diseases, especially when there's multiple chronic diseases, leads to an immunosuppressed state, so that there's an altered immunity and phenotype with reduced cell number and function, an increased immunosenescence, and more regulation of the adaptive immune system, all decreasing tumor surveillance, viral immunity and response, and an anti-tumor response, all leading then to cancer growth. I also want to highlight that we have even less understanding or appreciation for the risks and response to treatments of cancer in underrepresented minorities. And so there's much that we still need to learn about. If we pivot to thinking about mortality after cancer, we've thankfully noticed an improvement in mortality related to the four most common types of cancer in the general population. And that's especially the case over the last 30 years with changes in public health policies. So you'll notice a nice decrease in lung cancer over the last 30 years, along with improvements in colorectal, prostate, and breast. Much of that has to do with screening tools that are quite good in the general population. Unfortunately, that does not necessarily apply to our populations that we care for. This data from Australia also analyzed the standardized mortality ratio, meaning the likelihood of death from cancer on dialysis compared with the general population. And you'll notice a 2.6-fold higher rate of death in those on dialysis because of cancer specifically, with the most common causes of death being multiple myeloma, testicular cancer, and kidney cancer. And that era was broad from 1980 through 2014. And so I will acknowledge that a lot has changed in the course of the last 30 years of cancer care, cancer screening, and we probably need to reassess outcomes in our CKD and end-stage populations. I also will note that while we have more patients in Australia, the ability to analyze the data in a precise way is more challenging here because of a lack of standardization across registries. But that's an opportunity I think we can work with. So if we think about cancer screening as a very important part of care of our patients, at whatever stage of life they're at, I want to think about what it makes an effective cancer screen. And it requires a condition that is considered a significant health problem, that there's an acceptable and effective treatment available, especially for localized and early stage disease, because that's where the most effect in outcome change can be made. A trial-based evidence for early detection that improves morbidity and mortality is important. And then accurate screening tools existing to detect pre-symptomatic or latent disease is very important as well. And finally, integration of patient preferences and cost effectiveness has to be drawn into this. And I think that's where we often see that not every cancer has the ability for cancer screening at this point. In addition to the cost effectiveness or the accuracy of the tool, there are impacts on the patients, including the potential for anxiety, false positive results that lead to additional testing, treatment, and the negative sequelae that come with that. So I will acknowledge that we do need to be careful whenever we engage in cancer screening or any type of screening as to whether that's going to bring a positive outcome for our patient as best as we can understand. When we think about cancer screening for our CKD and end-stage populations, there's more of a challenge, and that's in part because our patients have chronic illnesses, and those result in competing risks of death. There's a lack of trial evidence for doing any type of cancer screening in CKD and ESRD patients because of them being excluded from previous trials. And as they are not screened as often, we often then diagnose cancers at higher stages. And of course, that impacts their survival and experience. Along with that, the CKD itself impairs standard cancer care, so that surgery in the setting of CKD and ERCD is associated with greater complications. Chemotherapies and immunotherapies are often either contraindicated or have to be adjusted in dosing because of that situation as well. So what that's led to and maintained is a recommendation by the ABIM and ASN to not perform cancer screening in patients on dialysis unless they are considered to be a transplant candidate. And of course, that is a question of what is acceptable for transplant candidacy, and therefore who should be screened. At this point, the most agreed upon pre-transplant cancer screening steps include applying the general population screening. And I've placed those here on the right. Breast cancer screening for those aged 50 to 74 is most common, with a mammogram every 2 years if negative. Cervical cancer screening starting at age 21 and with a pap smear every 3 years, and 30 to 65 every 3, or with HPV every 5. The colorectal cancer screening guidelines just were changed this May, updated to reflect starting at age 45. So many of us, even on the younger end of our faculty and fellowship experience, may be moving into that age population to be considered for colorectal cancer screening. Lung cancer is also now more commonly being screened for those who are ages 50 to 79 and have a 30 or more pack year history of smoking. In addition to the general population screening, there are some patients who do have a higher risk in other ways, maybe a family history that would predispose them. HPV positive state would require more frequent screening for cervical cancer, and hepatitis B and C would be of concern, especially for liver. We don't have guidance with regard to other types of cancer screening, especially in the CKD and ESRD populations, to much of an extent. I want to think back now 8 years ago to the last guidelines that were published on pre-transplant waiting times after cancer. And the reason why I'm bringing this up is because it's striking how much has changed in the last 10 years for cancer screening and cancer care. This is a table that was published with those guidelines. And what I'm highlighting here is that many of the cancers who previously would have been excluded for kidney transplant and probably would have had changes in care even with dialysis, now are potentially considered for transplant in the context of improved cancer screening and cancer care. And that includes renal cell carcinoma, breast cancer, colorectal cancer, and melanoma. We'll talk about those more in a minute. On the left, I wanted to highlight that much of our current management of patients with malignancy before transplant relate to whether they have achieved a remission, and are there some that are exceptions, cancers that are exceptions that can be managed even if they have not been fully controlled. Waiting time with HIV is likely needing to be longer because of the dysfunction of the immune system in the setting of HIV and when immunosuppression is added. So therefore, most would guide a slightly longer wait time for whatever cancer in that context. If one has an HPV positive anal or cervical cancer, those are often difficult to manage with immunosuppression and therefore contraindicated unless control of the HPV can be achieved to a significant extent. Oncology is definitely important in terms of managing and input, and the context of prognosis is, of course, significant. So I'm interested in your input on this, and I want to come back to our clinical case for a context of the question. So we have the 68-year-old person, has type 2 diabetes, high blood pressure, stage 4 chronic kidney disease, and we diagnosed him with stage 3A clear cell cancer. I'm wondering if you would have performed kidney cancer if he had not been a kidney transplant candidate or been evaluated for kidney transplant. So I'm actually going to ask Matt to come off of this screen for a second and use the poll to ask 3 questions of you. Matt, are you able to do that?
Launch that.
Thank you. Great. So I'm going to ask you to answer each of these questions. Do you perform kidney cancer screening on patients with CKD, knowing that right now there's not guideline to do so? Do you perform that kidney cancer screening in patients with end-stage kidney disease? And finally, based on your knowledge of the potential screening tools such as ultrasound, CT, and MRI, would you incorporate national guidelines if they were present for kidney cancer screening into your practice? And if you think we have a good response number, you can show it when you're ready.
We've got about 30, so I'll stop it here.
All right. Well, I appreciate you giving your input on this. So I'm seeing for CKD that 14% said they do perform kidney cancer screening, while 86% do not. In the end-stage population, slightly higher percent do, 36% do, while 64% do not. And if there were national guidelines for kidney cancer screening, 89% of you would incorporate them. Great. Well, I appreciate you answering those questions. At this point, as you probably know, there are no US guidelines to guide us in kidney cancer screening, either in the general population or in our chronic kidney disease and end-stage populations. And that's despite kidney cancer being one of the top 6 most common cancers, especially in our population. I've asked you about your screening at this point, and so I do want to think with you a bit about our current state of care for patients who do develop cancers. And this is just a figure, an illustration of how there has been a rapidly accelerated adjustment and attention to more precision or personalized medicine. And I know those are not interchangeable concepts of precision medicine and personalized medicine, but they, I think, can complement each other. And much like nephrology, I think oncology went through a period of time where there was not much available. There were a lot of side effects. And with time, with some risk-taking and some very innovative concepts, new molecular therapies, targeted therapies, and immunotherapies have come on board. And with that, new opportunities for improving people's lives, including probably getting them to kidney transplant when they previously could not have been, and likely impacting their care with kidney disease or dialysis, regardless of their transplant candidacy, has changed. This is a table that I created based on recommendations from a consensus group that were published in AJT this last year, looking at the current stages of cancer and the time from cancer remission or treatment to transplantation. And what I want to highlight for you is that compared with even 5 to 10 years ago, the time to transplant for patients with various stages of cancer, especially the 4 most common types, has shrunk in time, and that the unacceptable stage has gone up the ladder, meaning that people with breast cancer stage 3 are now considered potential transplant candidates if they can achieve remission Prostate cancer, almost all can be considered with appropriate treatment and response. Even lung cancer, after 3 to 5 years of remission. Colorectal cancer, you'll notice that there's no stage that is excluded in these recommendations from potential transplant. Now, this, of course, ensures or requires that patients are screened and have surveillance, meaning they're followed for potential recurrence of cancer, and that they're controlled and negative coming into transplant, because we know that immunosuppression is going to suppress a normal response. Kidney cancer, I think, is unique in that it's an example of a cancer that is very responsive to the immune system's control. And with the newest therapies, especially the immunotherapies, there's a chance to achieve remission and cure in ways that weren't possible before. And the wait times have decreased as well. You'll notice here, this is one of the tables from that consensus conference, and a stage T2 with N0, M0, meaning no lymph nodes or metastases, can get to a transplant in 2 years if otherwise acceptable. Our patient was a T3 and would have been a recommendation for 2 year at the minimum and follow for any signs of recurrence. Unfortunately, he did experience recurrence and was not a transplant candidate. But I do think that we have the ability to start to consider the various therapies for cancers as a part of the realm of care, regardless of someone's kidney health, in new ways that weren't possible before. And that includes the immune checkpoint inhibitors that are so much incorporated into standard cancer care now. That includes the CTLA-4 antibody. That it also includes the PD-1 and PD-L1 checkpoint inhibitors, but it also includes other types of targeted therapies against FGF, PDGF, VEGF, and tyrosine kinase inhibitors. All of those are being incorporated either alone or in combination to achieve better outcomes. But of course, there are still downsides, and those downsides include potential toxicities. For the immune checkpoint inhibitors, it's much like stimulating the immune system in ways that aren't necessarily as precise as we'd like yet, at least in the current era of therapy. And so we do see a variety of autoimmune-like responses that can be significant, and that includes nephritis. So if we ponder when a patient may be a candidate for transplant, and hence when could we list them after cancer treatment, there are organ failure factors, including can we achieve a life-saving transplant after achieving acceptable cancer remission. There are patient factors, including quality of life, and modifiable risk factors are really important, of course. Cancer factors we've discussed, including the time from treatment to potential transplant. And finally, there is immunosuppression related factors. How much suppression does one require to achieve adequate function of their transplant, or in the case of maybe a GN or another autoimmune disease, how much do we need to use in order to keep them well? I do believe that regardless of one's stage of kidney disease, a personalized approach to this is probably still the single most important thing. And I do list patient health and life goals at the bottom, yet it's the foundation for all of these other decisions about care. When it comes to that part of a patient's care, advanced care planning needs to be incorporated to a greater extent with our patients who have cancer plus kidney disease than even those who only have kidney disease. Those patients have higher symptom burden, including significant pain. They often have altered drug metabolism that limits the ability to use medications, including narcotics, as easily. Their survival, of course, is shortened. And in all of that, we've come to learn, especially with our great experts in palliative care here, that early palliative care assessment and engagement can only help our patients achieve more of what their goals are, including a better quality of life and length of life. So I'm going to finish by summarizing what we've discussed here and take any questions or comments. We know that cancer in the setting of kidney disease is higher than the general population, 1.5 to 4-fold higher. The most common cancers include urologic cancers, along with myeloma, skin, and to some extent thyroid. At this point, we're still needing to apply the general population guidelines for cancer screening as much as we can, along with those who may have a unique high risk. I would invite and advise that we utilize the prognosis and waiting times as we currently know them to guide transplant evaluation, but also just chronic kidney disease and end-stage kidney disease care independent of that evaluation. Immunotherapies may be valuable in patients, especially in the pre-transplant setting, yet we don't really know how long after someone is treated with an immunotherapy is it safe to then transplant them without leading to risks of either recurrent cancer, transplant rejection, or other negative effects. And with that, we'll continue and benefit from partnering with oncology and palliative care, along with other team members to optimize our patients' lives and their goals of life. I want to thank a number of people. Our patients continue to teach me, and I couldn't do the work that I'm doing without many others, including the transplant team, the folks who I get to work with at the SCCA, the research team that is working with me on the intersection between cancer and transplant, Dr. Simulfarb, DeBoer, Barotra, and also Dr. Jermaine Wong in Australia. Really appreciate many people's engagement, including all of yours. I'll stop and take any questions or comments. Thank you.
Thank you so much, Chris. Questions for Dr. Blosser?
Chris, this is Maggie. I have a question. Any information on risk of cancer in terms of stage of kidney disease, or was it all just sort of the pre-dialysis group together? Do you have a sense of that?
I'm not aware of literature that breaks down stage of CKD and associated risks other than a presumed relatively linear association as people move from stage 2 to 4 to 5 with more immunosuppressed condition in total, regardless of their cause for kidney disease, that they have a higher risk of cancer.
Chris, I have a question. So obviously it's as you've shown, it's quite complex about when following a cancer remission, a patient may be a transplant candidate. Again, it depends on the type of cancer, the stage of the cancer, et cetera. So as a practicing nephrologist taking care of dialysis patients, for example, like, do you have suggestions about how we can partner with transplant nephrologists as well as oncologists to figure out the best time to place a referral for transplant evaluation in a patient that we know has been treated for cancer and is now in remission? Like, should we be scrutinizing these tables to figure out the best time to refer? Should we be referring earlier and then having you all be making the call? I mean, I'm just curious what your thoughts are.
Yeah, thanks, Matt. I appreciate it. This is a complex intersection. When there's thought to be good control of a cancer, or it's showing signs of moving in that direction even, I think that we can invite a referral earlier and therefore allow more time to get that assessment and an answer. If there are complicated situations where a more unique therapy choice, such as an immunotherapy, or a question of whether that patient is truly responding, I would welcome either an email or alternatively, some of you know that I opened a multidisciplinary clinic at the SCCA September 1st, where patients are now being seen by a relevant oncologist and a relevant transplant physician in the same clinic. So for instance, this kidney cancer patient, had that person survived, they would have been a very relevant patient to be referred to that clinic for us to evaluate what are the appropriate therapies, if still in question, before transplant. How long would that patient do well to wait before transplant, and offer our best informed recommendation back to you or that patient's oncologist if it's outside the system. We have a lot to learn, and yet I think that we can continue to bring our current knowledge to the care that we offer and learn from each other.
Just a couple of comments in the chat, people finding this very helpful and exciting, and I agree Chris. Final question for Chris. All right. Well, thanks so much to our three speakers from this morning, and hope everyone has a great rest of the day and the weekend, and we will see you all next week.
Thank you. Have a good day.